This presentation is adapted from Sleep Academy, an online CME-accredited course for advanced practitioners and physicians. My name is Dr. Peter Sloan, and I'd like to introduce Dr. Brian Bonner.
Let's review the basic fundamentals about restless leg syndrome and parasomnias. Although the conditions that we're going to be addressing here are movement disorders of sleep, they actually are categorized separately, restless leg syndrome and then the parasomnias. Yet we're going to be addressing them side by side, and along those lines we're going to start out with the fundamentals first of restless leg syndrome, and then we'll finish up with the fundamentals about the different parasomnias. Restless leg syndrome is a chronic progressive sensorimotor disease that affects the lower extremities. It is also known as Willis-Ekbom disease. The condition is very common and affects as much as 10% of the population, when including even mild degrees of restless leg syndrome. The syndrome is explained by alterations in iron metabolism and dopamine synthesis. Women are affected twice as often as men, and Caucasians are most commonly affected. In most studies, it's suggested that Scandinavian populations have this with the greatest prevalence. 60% of patients with restless leg syndrome have a family history, and many of these have a autosomal dominant form of familial restless leg syndrome, and therefore the patient will have one or both parents that have restless leg syndrome, and perhaps other family members with it. And very often when you talk to the patient, this may be already known, and sometimes it's not known because it's not a common topic among family members, and sometimes has remained a secret for years because it's never come up in conversation. It's also important that patients who have restless leg symptoms, the sensory part of it that occurs during waking hours, is accompanied with the motor manifestation of this during sleep. So 80% of RLS patients also will have movements of the legs during sleep, often noted by a bed partner and often not recognized by the patient. The clinical features of RLS, and this again is a chronic and a progressive disease, and the sensory and the motor elements can be disabling to the patient, but usually it's the sensory symptoms that actually bring the patient in for therapy. The symptoms can vary from mild to disabling. There have been several studies that have actually compared the quality of life severity scores compared to other neurologic diseases such as multiple sclerosis and Parkinson's. And the scores in large populations show that the RLS patients can have just as much impact negatively on the quality of their life because of these symptoms. In the early stages, the legs alone are involved, but later on it can involve the arms and the trunk. The condition is linked to our circadian cycle, and these dysesthesias occur usually in the last few hours of wakefulness. And then the motor manifestations of the process, the periodic limb movements or the kicking, generally continue then through the first few hours of sleep. The dysesthesias are often difficult to describe. The phrases such as a creepy crawly sensation to itching, throbbing, feels like soda running through my legs, feels like bugs running through my veins, many different descriptions. And then some people just say, I can't really describe it, but it's a miserable feeling. The diagnosis of restless leg syndrome is a clinical diagnosis, and the features are noted here. This does not require a sleep study to confirm the diagnosis, nor can a sleep study establish the diagnosis. So the mnemonic urge that you see spelled out from top to bottom there corresponds to the four essential elements to make the diagnosis of RLS. And the U refers to that urge to move the limbs as a result of an unpleasant feeling. The R refers to the fact that the symptoms are worse with periods of inactivity or rest. And the G is kind of the weak part of the mnemonic here, but it can be remembered by get going so that it's better with activity. If a patient moves around or walks or stretches the legs, it can ameliorate the symptoms just with that activity. And evening, the E part of this refers to this predominant time that occurs, again, supporting this as being a circadian linked syndrome. The pathophysiology of RLS is not completely understood, but the current theory is that there's an iron transport dysfunction resulting in a reduced level of activated dopamine in certain regions, particularly in the midbrain, noted in the center part of this anatomic diagram. And this is the area of the basal ganglia where the rich dopamine areas are located. To take a closer look at that area, this is the region known as the substantia nigra in the basal ganglia, and the arrow is pointing to the black areas, and nigra meaning black. This is where the pigmented areas of neuromelatonin are located, and this is where the dopamine-rich areas are. And in RLS patients, the degree of dopamine, the measurement of dopamine is reduced, and there's low levels in the intracellular iron, yet there is high mitochondrial iron. So it is felt that this is an iron transport dysfunction that's responsible for patients' symptoms.
If you'd like to learn more, please visit our educational center at pulmonaryandsleepacademy.com, where we have 70 hours of self-paced online CME-accredited courses covering pulmonary, sleep, cardiology, and critical care medicine. Please enjoy more of our short visits on our PSA YouTube channel. You can purchase our full courses with an exclusive 10% discount code using YouTube10.